X-ray and monitor, ventilator monitor, showing graphics. Among the two, which is more useful for continuous monitoring? X-ray is useful for initial diagnosis and for planning of the management. Which is useful for continuous monitoring of the baby? Definitely ventilator graphics. So X-ray just gives initial, it makes diagnosis. It is useful for making the diagnosis and for planning the treatment, that's all. That is only 1%. 99% of the time, for continuous monitoring of the patient, these graphics are important, ventilator graphics. Okay? Because in X-ray, we don't know about pressures. We don't know about peak inspiratory pressure or even plateau pressure. We don't know about transpulmonary pressure, pleural pressure. We don't know whether patient developed autopy, positive and expiratory pressure. We don't know about static compliance, dynamic compliance. There are many factors which influence lung injury. Okay? Even abdominal factors, intra-abdominal pressure. High intra-abdominal pressure can influence transpulmonary pressure. Various factors, they are mainly important in the management. X-ray doesn't give any information except for making the diagnosis and for planning the management. That's the point for X-ray. Mainly ventilator graphics, we have to continuously monitor the ventilatory graphics. So VILI, ventilator induced lung injury. Actually, main injury is due to the alveoli. Main injury is to the alveoli. More than airways, ventilator mainly induces alveolar injury. Actually, that VILI is a misnomer. How can ventilator induces lung injury? Suppose if there is car accident, how can a car cause accident? We will blame car or we will blame driver or traffic system. If there is car accident, we will blame the car. Can we blame the car? Or we have to blame either driver or traffic system. Similarly, VILI is a misnomer. How can a ventilator cause lung injury? It won't cause. Either the disease itself or operator. It's called physician-induced lung injury. Mostly 99% of situations, disease itself. The disease itself will cause lung injury. Inexperienced hands, that is operator-induced, physician-induced lung injury. Okay? Ventilator is a lovely machine. How can it cause lung injury? Only disease will cause further lung injury or operator. The best institutes in US or UK in best ventilatory setups, mainly disease will cause that injury. In 90% of the cases, the disease will cause injury. In developing countries, in 90% of situations, operator induced, physician induced. So, in that models, just after 20 minutes, there is severe biotrauma. So, 20 minutes of high pressure can cause severe biotrauma to the lung, severe inflammation and edema to the lung. There are various traumas, atelectatic trauma, barotrauma, pressure-induced trauma, barotrauma, and volume trauma, high tidal volume. If you give high tidal volume, that is called volume trauma, high tidal volume induced trauma. If you give high pressure, that is barotrauma. Atelectasis, atelectotrauma. Again, there is biotrauma. Biotrauma means there is inflammation edema to the entire lung. So, just 20 minutes of high pressure, high volume can cause severe biotrauma. So many factors are involved in the lung injury. In the respiratory mechanics, we should have at least approximate idea of lung compliance. We have idea of lung compliance, lung resistance, lung conductance, elastance, capacitance, inertance, impedance and reactance, and stress and strain of the respiratory muscles and lung. We should know when patient is on ventilator, we should know the mechanical power induced by the ventilator. So there is various factors are involved. We should know lung compliance, resistance, elastance, conductance, capacitance, inertance, impedance and reactance. What is pulmonary reactance? Pulmonary reactance is ability of the lung to store energy during passive expiration. During passive expiration, that is during elastic recoil of the lung. Ability of the lung to store energy during passive expiration, that is reactance. Inertance means total impedance to the lung. Again, for resistance, there are various factors: maximum resistance, minimum resistance, resistance secondary to, it depends on airway diameter, when compressed air resistance, and resistance secondary to air density, viscosity, flow patterns. Okay. Even for compliance, there is static compliance, dynamic compliance, and total compliance of the lung, specific compliance of the lung, hysteresis part. So information along all these factors, we can get almost full assessment in the ventilator graphics. So those graphics are very important. The continuous monitoring of these factors are very important. We should know the stress and strain lung or chest wall is facing. We should know the mechanical power of the ventilator. Most importantly, we should assess the transpulmonary pressure, pleural pressure, and other factors like abdominal pressure. Even cardiovascular hemodynamics we should monitor. Even in ARDS, alveoli they are heterogeneous. Whether alveoli are distensible or non-distensible, whether alveoli are recruitable or non-recruitable. These alveoli are distensible alveoli. With increased tidal volume, there is distension of alveoli. These are distensible alveoli. These are non-distensible alveoli, non-recruitable alveoli. So, what is this breath pattern? What does it indicate? What does it indicate? This is spontaneous breathing. The simple spontaneous breathing, because flow pattern is sine wave pattern. Flow pattern is sine wave. This is spontaneous breathing. What does it indicate? Again, flow pattern is sine wave pattern, but there is CPAP. The baseline pressure is at this point. So it is simple CPAP. Simple CPAP mode. This one, three factors are important. Last time we discussed what triggers, what controls, and what cycles. What triggers the breath, whether it is patient triggered or machine triggered. What controls, whether it is pressure control mode or volume control mode. What cycles? Cycling means change from inspiration to expiration. Change from inspiration to expiration, that is cycling. What factor involves cycling phase? These three are important. So here, what triggers the pressure time scale? Three scalars. One is flow time scalar, pressure time scalar, and volume time scalar. The three scalars and two loops. So what is this mode? What triggers? What triggers, patient or machine? Patient triggered. This is patient triggered, because there is initial negative wave. So this is patient triggered. Then pressure support mode with CPAP. Patient triggered with the pressure support and CPAP. Again, trigger. What triggers, patient or machine? Again, patient. With pressure control or volume control? Pressure control, because pressure here is constant. That square is in the pressure time scale. So it is pressure control. This one, patient triggered or machine triggered? Is machine triggered. Here there is no initial negative component. This is machine triggered. Then what controls? Volume control, because in flow it is square. The square wave is present in the flow. Volume control. Cycle? time cycle. At particular set time, inspiration ends. Okay. Again, patient or machine? Time triggered. Machine means time triggered. Time triggered. And control? Pressure control. Okay. Cycle, again time cycle. Okay. Mean inspiration ends at a set time, set inspiration time. Okay. This is the TI, inspiration time, and this is expiration time, TE. From this point to this point is the total cycle time, TCT. So what is the abnormality? V dot means flow. Is flow time scalar. A flow time scalar, this is inspiration, this is expiration. In the expiration, we should look for PEFR, peak expiratory flow rate. And we should look for the slope and end expiration and expiration time. These four are important. Here in the end expiration, it should touch the baseline. Normally, at the end point of expiration, should touch the baseline. But here it is not touching the baseline. It ends here. It ends here means there is auto peep. This is auto peep. This indicates auto peep. This indicates this is PIP, peak inspiratory pressure. This is plateau pressure. PIP is increased. Yeah. Increase the trans airway pressure. This one. In the volume time scale, what is the abnormality? This is inspiration part, this is expiration part. In the expiration, again end expiration, it should touch the baseline. End expiration, it is not touching the baseline, it ends here. It ends with either PEEP or air leak. Two possibilities. There are two possibilities. For that we have to check other two scalars. We have to check flow scalar. In flow scalar is suggestive of auto PEEP. So it must be auto PEEP. So PEEP, CPAP, EPAP, all are same. They all increase FRC, functional residual capacity. If we want to increase functional residual capacity, we have to increase CPAP. If we aim for tidal volume, we should give pressure support or increase tidal volume or respiratory rate adjustment. So how to know the ideal CPAP? Optimum CPAP. How to know optimum CPAP? How much CPAP we have to give? So for that, in pressure volume loop, we have to look for lower inflection point and upper inflection point. So 0. Suppose if lower inflection point is at 10, we have to maintain at least 2 to 3 centimeters of water above 10. If lower inflection point is at 6, we have to give 8 CPAP. We should look for upper inflection point. If our upper inflection point is 20, we should maintain CPAP below 20. So optimal CPAP is between lower inflection point and upper inflection point. This is atelectatic zone. This is safe zone for CPAP. This is power distension zone. What is lower inflection point? Minimal CPAP to open alveoli. Here it is collapsed alveoli. So at lower inflection point, at this point of pressure, alveoli are opened. This is opening pressure. So we have to maintain minimum CPAP above lower inflection point. Here they are over distended. We should maintain below this point. This is called the safe point or sweet spot. This is called sweet spot, but safe zone for CPAP. Zone of de-recruitment atelectasis is safe window in between lower inflection point and upper inflection point, and that is over distension. So these sensors, actually alveoli, tubes and bronchi, but what sensors nowadays in the advanced modes, the sensors are in the proximal part, proximal flow sensors. Directly we don't get any alveolar pressure information or even bronchial or airway pressure information. Only tracheal pressure. The sensors, they will assess the tracheal pressure. Even in the pressure times, in the pressure time scalar or in pressure volume loop, in the pressure time scalar we will assess peak pressure. In the volume control mode, inspiratory held breath, we can measure plateau pressure. We can measure peak pressure, and in volume control modes, the inspiratory hold, we can measure plateau pressure. But we don't know pleural pressure, we don't know transpulmonary pressure. So among the three patients, which is more oxygenated? Which patient doesn't need PEEP? Last one has PaO2 65. PaO2 65 but with room air. So PaO2 by FiO2 ratio is important. More than PaO2, that ratio is important. In the third case, PF ratio is 309. Just you can increase oxygen, that is enough to maintain PaO2 of up to 80. In the first case, PaO2 is 81, here PaO2 is 120, but PF ratio is low. That PF ratio is important. For PF ratio, every time we have to take ABG. To assess PF ratio, every time we have to check ABG. So usually we will check SiO2 by FiO2 ratio, saturation by FiO2 ratio. Pre-surfactant, and this is pre-surfactant, this is post-surfactant. But post-surfactant effect, we can assess the post-surfactant effect only in loops. The immediate effect will be seen in these loops. Ventilator graphics are important for continuous monitoring. Even for bronchodilator effect, the pre and post bronchodilator effect that will be immediately seen in loops and scalars. We can't take another X-ray, we can't do a spirometry test or another CT scan, they won't help. Even endobronchial ultrasound, bronchoscopy, they won't help. Only ventilator graphics, the scalars and loops, they will give continuous assessment of our treatment. Suppose after few weeks on, patient is on ventilator, after few weeks, if you find sudden airway collapse in the expiratory limb, that's an important finding. If you find this airway collapse noted on expiration limb, and in the loop, the pressure volume loop, there is sudden scooping, that indicates tracheal malacia, tracheobronchomalacia. The prolonged ventilation can cause the tracheobronchomalacia, that will be identified early in scalars and loops. If you observe 8 pattern like that, inadequate pressure support, there is sawtooth pattern, a zigzag pattern in the expiratory limb and in the inspiratory limb, they indicate secretions. So patient A and patient B is volume control mode or pressure control mode? A. Pressure volume loop, and this is flow volume loop. This is volume control, VC mode or PC mode? This A. That B? That B looks like volume control? A, here pressure is constant. Okay, that is volume control mode. The last case, newborn with viral infection mode. Okay. But only abnormal finding is in the expiratory limb. Initially, intensively suspected some secretions, but there are no secretions. Even after suction, this pattern, observe this pattern. So, what is abnormality in this expiratory flow? Finally, they found out that there are cardiac oscillations, heartbeat observed in expiratory flow, cardiac oscillations in the expiratory flow. Abnormal blood vessel is obstructing the trachea, tracheal compression by the double aortic arch and abnormal blood vessel. After observing this, they did echo and they observed an abnormal vessel compressing trachea. They did a surgery for that patient. Apart from respiratory mechanics, we can assess even cardiovascular hemodynamics also. Okay, thank you. Okay.